Hi, everyone. I'm Amber, and this is Eleah. Thank you so much for that introduction, and thank you, CLL Canada, for inviting us to present today. I am thinking of caring for yourself as really living well. So, how do we live with a disease that is going to be around for the rest of your life? And while we might not get through absolutely everything today, we will get through a few topics. So these are our collective disclosures. We're using one slide deck just for the sake of time. And so what is wellness? Well, I like this definition from the Global Wellness Institute. So wellness is the active, conscious pursuit of activities, choices, and lifestyles that lead to a state of holistic health. And in today's session, we're going to give you, like I said, this crash course. And so we're not I do apologize that we are not addressing some of the psychosocial or psychological aspects of going through a cancer diagnosis. We are focusing more on sort of this biomedical support. And in turn, I think some of that support does help some of those things, like we'll get into the presentation. So I'll be presenting on the first three topics, and then we'll hear from Eleah on nutrition. So, preventing infection. So this is a big thing in CLL about living well, which is just trying to stay as healthy as you can. And we've gone through a lot of the immune system already. We've heard from many presenters. But basically, this immune system, or the immune system, is a snapshot of immune organs. There's anatomical and physiological barriers like the skin, the mucous membranes, and it also contains these immune cells in the innate immunity and the adaptive immunity. So when I was thinking, CLL specifically impacts the innate and adaptive immune systems, and I was trying to think of a creative way of explaining this in a short period of time. I do come from an arts background once upon a time, so I was trying to think of an analogy about how I would explain this, and I was thinking about my 6-year-old he likes sensational news stories. And last year, there was a news story that made international headlines, which was the heist of the crown jewels at the Louvre. So you're just going to have to bear with me. These things will connect, but this is the next slide. So here we have, this is the AI version of my thought process. I gave it some prompts. This is what it spat out. And we're just going to go through this a little bit. So you'll see kind of on the left side, I think, is this innate immune system. And we can think of that as kind of like the front door bouncers of the immune system. So these are your first responders to unwanted threats. So in that case, it might be bacteria, viruses, unwanted chemicals. So these are the people that are going to act really rapidly, and they're going to clear some things. So if you sit on a toilet seat, they might clear that for you. And that's what we want. We want our immune system to just be continuously, kicking out the bad guys. You will notice, and I think hands up if you've had your blood work and you look at your neutrophil count. So I get a lot of patients asking me about this, of how, we'll get into this a little bit later, but if my neutrophil count is in a normal range, why is it that I'm still considered immunocompromised? Because we typically think about that as like the function of our immune system. And that's because in the background, there's a whole host of other things that are impacted by CLL, and that's the adaptive immune system. So we know that, CLL it affects the B lymphocytes. So we see the adaptive system is composed of these B cells, T cells. For simplicity's sake, we'll stop there. And the function of the B cells is to create antibodies. And these antibodies basically looked at, I guess ChatGPT did not get that right, but basically they do two roles. So they attach onto the cellular surface, but they also create a memory, which is like that stored memory in those cameras. So if something happens again, you see the same virus or bacteria again, they're going to remember it, and they're going to act faster the next time. the T cells, well, all of this is happening in normal conditions. They also directly attack bacteria, but also cancer cells. But when these B cells are not working properly, these T cells, you've heard today that they get exhausted. They're doing all of the work. So basically, CLL, it impacts both of these systems, and that's the reason why your immune system is lower, even if you see like a normal blood work. So again, CLL, going back to that adaptive immunity, what we can see is low antibody production. So CLL primarily impacts, if you get your immunoglobulin panel, you'll see a bunch of them, but it can particularly impact the IgG and the IgA antibodies. And so IgG is low in approximately 60% or 2/3 of people with CLL. And the hallmark of this is recurrent infections. So this could be bacterial or viral, particularly respiratory, sinus, and skin infections, amongst others. And if you have recurrent infections, then it might be time to start something called IVIG, which can, you're replacing that low immunoglobulin. It gets a little bit more complex because some people can have a normal IgG and actually still have recurrent infections. So it's just something to kind of, I guess, parse out with your healthcare provider, your oncologist. So again, CLL, you can have bacterial, viral, fungal infections, as well as opportunistic infections. And these are infections that occur only in people who are immunocompromised or have a weakened immune system. And what can happen also is just that you can get these like secondary types of infections. So because your immune system is down, people are more prone to getting things like colds that turn into other things. So, sinus infections, pneumonias. So estimating personal risk is very tricky. So just like a snowflake, we know that no two patients' immune systems are alike. One of the easier predictors is the amount of disease burden, which we sometimes see as that elevated white cell count, the amount of lymph nodes, a large spleen, et cetera. And when you're but it gets a little bit more tricky because after that, other things that impact your immune system are things like age, other chronic conditions that you have, including some of the treatments for that, your IgG antibody levels, your personal infection history. So this includes some people, they get, things like COVID, for example, and they get over it. They were barely sick. They had a sniffle for a day, they were fine. And that's kind of a little bit reassuring. But when people end up getting quite more serious types of infections take longer to clear or get that history of kind of like always sick, then you're kind of thinking maybe, this person's immune system is down. And then, of course, there's a whole different thing on past or current treatments as well that may increase your risk for certain types of infections. Managing your risk, I think everyone here is very familiar because we've all been through COVID, so it doesn't matter where you are through your cancer journey. We all have that shared experience, but it's the basic stuff of avoiding sick contacts, hand hygiene, masks in like really cramped environments like the plane, for example, avoiding giant crowds. So maybe if you know that your immune system is down because you've been sick a lot, it's just avoiding things like the grocery store at peak times, like stuff like that. And vaccines, they are a bit personalized, I would say, but we still recommend getting having your vaccines up to date, even if because of your CLL, you don't mount the same immune response. So some coverage is better than no coverage at all, but another key component, and maybe even more importantly, is having the people in your household or people that you have come in close contact with having their vaccines or age-appropriate vaccines around, so on board, so that basically they're not passing along those germs to you, and you're creating that kind of like bubble of herd immunity. The other side of the coin of managing infection is early intervention. So that is, just notifying people of serious infections, but particularly things that linger on for quite a long time and get progressively worse and they don't get better. So again, that classic example that I've shared is just that someone has a cold, and that cold doesn't go away and turns into a sinus infection, like that kind of stuff. And then just kind of identifying things that you can identify quite quickly. So like shingles is a common, type of viral infection, and COVID. So, identifying those things and then notifying someone really early, because certain antivirals can work, but there's a therapeutic window, and it's pretty short, of when these things are actually going to be effective. The other thing, again, the immune system does is it attacks cancer cells. So we know with people with CLL, there's a greater risk of developing secondary cancers, and particularly skin cancers. So skin is an immune organ. And especially for the skin cancers, the squamous cell and the variety, and as well as melanomas. This is getting regular skin checks in the province of BC, and depending on where you live, it might be very hard to get an official dermatologist to look at your skin. But most importantly, that you're actually having a thorough skin exam and getting people, if you live with somebody, to check things like your back. So any non-healing lesions, new spots, or moles that look a little bit different, so changing color or size or shape, you want to get those ones looked at. And then keeping up to date with your routine age and risk factor cancer screenings for the things that you can control, as well as, just kind of using things like extra sun protection, even when it's not sunny out. So I'm going to really briefly speed through a few of these things so we can get to Eleah's talk, but this is managing fatigue. So this is something that often is it's a big part of having CLL. Around 77% of people with CLL experience cancer-related fatigue. And it's important to distinguish this is much different than other types of fatigue in that it does not improve with rest or sleep. You are living with it. This is probably something that you already know about. But naturally, when you're not feeling like yourself, we hear, many patients compare themselves to how energetic or productive or active they were before their cancer treatment. And this state of comparison is a common phenomenon that behavioral scientists refer to as the contrast effect. So people judge their current situation by comparing it to a previous experience rather than evaluating it on its own accord. And this is something that the brain just does naturally. It focuses on that gap between the old me and the current me. And I think that this can really intensify emotions such as grief, frustration, just because you're not feeling like yourself, and it's a big quality of life indicator. There's so many causes, and there's so many unknown causes related to fatigue. So that's kind of important to distinguish. So obviously the cancer itself can cause fatigue. The treatments that we give, where you're at on an emotional scale, other chronic conditions. And there's many things that we can measure, though, that we can modify by taking blood tests. So those tests might be something like your B12 levels, your ferritin, your thyroid. Obviously, we always see that hemoglobin. And those are definitely things that we might look at for other things related to fatigue that we can help you with. And we'll listen to, Eleah's presentation on nutrition, but that has a big role. If you're not getting the calories or the proper hydration, that's going to play a part. So we'll, some of the other non-medical strategies. So I like this analogy of working within your energy envelope. So it's identifying the time of the day that you're the most energetic and prioritizing the tasks that you need to do or the things that you find important within that envelope. And communicating that with the people around you. Pacing yourself throughout the day, but not taking too many naps. So there's a whole thing on sleep studies, and some people have done some important work on identifying like the perfect nap, which is 20 minutes. Otherwise, you end up getting into another sync sleep cycle, and it can disrupt your nighttime sleep. So you don't want to be like a raccoon at night and then sleepy all day is basically the thing. So it's just using those types of strategies. And honestly, the stuff on sleep is just evolving, very fascinating, and could be a whole talk in and of itself. I'm going to briefly talk about exercise. We all have probably heard exercise is good for us. But this slide was circulated last year. So because this is a brief talk, I encourage you to go on the CLL Canada website. There's a great talk on exercise specifically. But what I like about this is you can see the cancer symptoms, and then you could match those symptoms with the amount of exercise or what goals you might want to have in terms of your life. And sometimes that helps become like a big motivator. But overall, basically, for overall total health, it's 150 minutes a week of aerobic exercise and twice a week of resistance training. So that doesn't mean just lifting weights. It could be using like exercise bands, really anything that puts a load on your muscles. So practical strategies. So that's all very well and good, Amber. I don't have an exercise plan currently, and I might be also dealing with other conditions or mobility considerations that make that target really, really difficult. So really the message is any movement is better than no movement at all. And we know just from like just general conditioning that if you don't move it, you lose it, or whatever that saying is. I think we've all heard it. It's basically you just have to try to incorporate some movement into your daily life. We know people that live in blue zones, for example, are the healthiest people in the world because of diet, exercise, and social connections. And they're not necessarily going to a HIIT class. They're working, they're using movement in their daily life, and they're just generally a little bit healthier. But it's things like, maybe some people that's setting goals to work towards that 150 minutes, twice weekly. Some people, you can wake up in the day. It was like, what's one thing that I can do today to move more or increase my energy? And it's kind of making it fun and social, I think. So that might be it for me. Thank you very much.
Awesome. Well, thank you for having me here today. So we are going to start by looking at healthy eating guidelines from a very general perspective. Then we'll move down into healthy eating for cancer, for CLL, and then we'll finish up discussing or sharing some results from some of my work on intermittent fasting in CLL. All right, so this picture here is from the most recent version of Canada's Food Guide that came out in 2019. You may remember from previous versions that nutrition recommendations were often given based on a certain number of portion sizes or serving sizes recommended per day, such as 5 to 8 servings of fruits and veggies per day. We have moved away from that now to looking more at the proportions of the types of foods that we're eating. And I actually have a very strong preference for this model because it more tightly aligns with healthy eating for cancer. So as you can see on this image, we're aiming for most of our meals to have half fruits and veggies, a quarter be your protein foods, and then a quarter be your whole grains. And the rationale for this is that it helps support healthy blood sugars, but it also ensures that we're getting the protein needed to maintain your lean body mass or maintain that skeletal muscle, which also helps reduce morbidity and mortality in people with cancer. Eating in this pattern can also help ensure that you're getting all of your micronutrient needs. So it ensures that you're consuming all of those vitamins and minerals that you're needing for optimal enzyme production, bone health, etc. But we do have some more specific guidelines specific to those with cancer. So there's an amazing organization called the World Cancer Research Fund. They partner with the American Institute for Cancer Research. So I have just put a little link to the website down here in the bottom in case you want to look this up more afterwards. But there are a few points that are very heavily researched and very heavily supported with evidence as foods that we want to incorporate more of into our diet for those living with and beyond cancer. The first one is aiming to include a wide variety of colorful fruits and vegetables into our diet. I know the old saying of eat the rainbow sounds very basic and perhaps childish, but there's quite a bit of science behind it. And that's because all of these different colors of fruits and veggies have their own distinct phytonutrients, phyto meaning plant. So, for example, different types of antioxidants. So eating this wide variety, these phytonutrients work synergistically to help reduce or keep down that low-grade inflammation, and then can also help combat any type of oxidative damage within your healthy tissues. The next recommendation is eating plenty of fiber. And this recommendation has been out there for quite some time. So I put the daily goals for both women and men on this slide. But a lot of the new research is actually looking into the nuances in the importance of the variety and the specific types of fiber in relation to changes in the gut microbiome. The gut microbiome produces all of these tiny little metabolites that can circulate throughout your system, and new and upcoming research is showing that there may be some crosstalk between those metabolites and our immune system, which of course could have implications in CLL. So fiber definitely plays an important role here. Next is omega-3 fatty acids. So omega-3 fatty acids is the one type of oil our body is not able to produce. So for example, if we eat omega-6, we can produce omega-9, but we're not able to produce omega-3s. So we do need to be getting these through our diet. Our richest food source of omega-3s is our cold water fish. So salmon is an excellent example, but we do have some plant-based sources like chia seeds, hemp hearts, and even some vegetable-based oils, like say an olive oil and canola oil, do have a little bit as well. If these are foods that you don't have in your regular diet, omega-3s is one of the supplements that I will sometimes support in people with cancer. So you can always ask your dietitian if you want any specific recommendations on types of omega-3s or how much omega-3s you should be taking. Next is aiming to have lean proteins. Again, we really want to keep up that muscle mass to help support our weight overall. And having some lean proteins like chicken, turkey, eggs, dairy, and shellfish are some nutritionally balanced proteins to include. And ideally, we want to supplement those with some plant-based proteins as well. So these are things like your nuts, your beans, your seeds, legumes, and having some of these plant-based proteins will also help you meet your fiber goals. So these are the foods we want to include as much of as possible. But we do also have some guidelines on some of the foods that we want to limit. So these are primarily red and processed meats. Still okay to have some of them. We just don't want to be having these on a daily basis. So the less we have, the better. Same with our ultra processed foods and alcohol. So if we were to just sum up eating for cancer, I would probably throw the priority into these three main buckets. Eat lots of plants. So lots of fruits, veggies, whole grains, nuts, seeds, and beans. Aim to have enough protein. So there is a little calculation on the bottom here if you're interested. Once you have your weight in kilos, we're aiming for a similar amount of that in grams of protein, and to limit ultra-processed foods. And now we'll move into nutrition for CLL. So we've heard a lot today about some of the symptoms and the side effects of the various treatments. And I just want to put a plug for the role that nutrition can play in helping manage some of these. So Amber just spoke really eloquently about the role of healthy eating and exercise in managing fatigue. And I do also want to mention that with anemia, while there's different types of anemia and different causes of anemia, we do still need adequate amounts of iron and B12 to support our hemoglobin. So that's something you can always discuss with your hematologist about. And I've listed a few high iron and B12 foods on this slide here. A few others that we see quite a lot is unintentional weight loss. So this is when people are losing weight without trying. And while at the beginning this may not seem very concerning, when that trend continues over time, it can leave us in quite a dangerous situation. So if this is something you're experiencing, or if you're also experiencing other symptoms like say a lack of appetite or early satiety from that abdominal fullness, or other GI symptoms like diarrhea, ask for a referral to your dietitian. Um, Tackling these types of side effects does tend to require a very personalized approach. We'll work with you to find foods that will work with your daily lifestyles and habits. All right, and now I'm going to transition over and just sharing a little bit about my work on intermittent fasting in CLL. And first of all, I would love to see a show of hands of whether anyone here in the room has ever tried any form of intermittent fasting at any point in your life. Okay, so I'm seeing quite a few hands. I would say at least half the people here. So I'm often asked, Eleah, why did you choose intermittent fasting in CLL out of all the nutrition topics you could choose? And the reason why is because I receive so many questions from patients on exactly this topic. Um, Patients were wanting to know, oncologists were wanting to know, and dietitians were wanting to know. We really didn't have an answer. One day, our medical director at BC Cancer in Victoria, who happens to be an oncologist treating CLL, came and knocked on my door. And he just said, Eleah, I had a patient come into my office with all of these studies about the benefits of intermittent fasting in CLL. And he's like, I just stared because I didn't know what to say. What do you think? And my initial response was, you know what? This is just a fad diet. It's going to come and go. Sent the oncologist on his way. Then afterwards, I thought, you know what? That was very irresponsible of me. I'm going to do a deep dive into the literature and see what the evidence is actually demonstrating. And when I did so, I found that some of the preclinical studies, so our animal model studies, as well as some of our lab-based wet lab studies, so where they're working in single cells, was actually quite intriguing and had me thinking there might be something to this. So I wanted to investigate further. But of course, we are not animals. We are not eating mouse chow. So my first step was to find out what trials had been conducted in people, so in humans with cancer. So this was just a figure from a study that I published early in 2022. I just did a quick search on clinicaltrials.gov, which is our main clinical trial registry here in the West, just seeing what types of trials are being done on fasting in cancer. And what you'll notice through this figure is the first one is registered in 2009, but we're seeing quite a rapid increase in the number of studies being done. The different colors and shapes are just denoting the different fasting methods that were being used, as well as the status of that study. I strongly suspect that if we reran this exact same search today, we would see a nearly vertical line and this chart would be off the graph. We just have so many more studies in this area. So knowing that we had some clinical literature in this area, I wanted to pull together that body of evidence to see exactly what it is saying to help inform our clinical practice. So we ran the systematic literature review in 2024. We identified 24 entries. Out of those, only 10 were completed studies. So of these 10, unfortunately, we couldn't draw any strong conclusions because we heard about the heterogeneity in CLL. There was a lot of heterogeneity also in these study designs. So they were using different forms of time-restricted eating, which is a type of intermittent fasting. They were being done in different tumor types, so it was done in all different types of people with cancer. And perhaps most importantly, they were looking at different outcomes. So they were all measuring different things. And as a result, we really couldn't compare our findings because we were comparing apples and oranges here. However, there were a thread of consistencies throughout these 10 studies, and that was that adherence rates, so the ability for patients to actually follow through these diets, was extremely high, with 70 to 100%. We also saw positive changes in body composition. So patients were maintaining that lean body mass while losing weight from adipose tissue, which is your fat tissue. So that's a very healthy type of weight loss. And patients were feeling better when they were following this diet pattern. So knowing this, I then wanted to conduct our own study here at BC Cancer so we could kind of design it in a way that we felt would work well for the patients based on feedback we were receiving. So I wanted to explore a specific type of time-restricted eating that's commonly referred to as the 16-8 IF, or 16-8 intermittent fasting. And this is where individuals are limiting their eating window to only 8 hours per day and then having just water for the remaining 16 hours. We provided our participants the option of when they wanted to eat within this 8 hours. So some chose it earlier in the day, like say 9 to 5, while others prefer to eat later in the day, like noon to 6. We also provided individuals a single day off the intervention. so they only had to follow it 6 days per week. We recruited 15 participants. Ideally, or initially, we asked them to follow the 16-8 IF for 3 months and then return to their normal diet, and we would follow to see what happened when they went back. However, partway through the study, a few people came back and they said, "Hey, Eleah, I'm actually feeling so much better on this 16-8 IF. I don't want to go back to my normal way of eating." We were not anticipating that, but we wanted to be responsive to the feedback that we were receiving. So we then amended the study to allow people to either fast for 3 months and then go back to their normal diet, or just fast for that entire 6 months. And as a result, we ended up with these 3 cohorts of people. So we had 2 groups that fasted for 3 months and 1 smaller group that fasted for a full 6 months. So now I'm going to quickly take you through just a few of the results before we wrap up here. And by no means are these all of the results that we looked at, but there's some of the ones that I feel are most intriguing and perhaps relevant to you. And the first is our clinical results. So what we did was we were monitoring the changes in their lymphocytes before they were on the intervention, during the intervention, and after the intervention. So each line here represents a different participant in our study. The blue dotted lines on the left is someone's individual lymphocyte growth rate for the full year before they joined the study. So as we know, with this disease state, the lymphocytes tend to slowly creep up. Of course, there can be some ups and downs, but they're generally trending upward. And then once they were on the intermittent fasting, which is the yellow line here, we were able to then also take a look at the changes in their rates. And then we followed that when they were done. And there's a few things I want to point out. So the first, maybe I'll grab the pointer here. These first 3 participants with the red circle here, what you're noticing is that once they had completed intermittent fasting, their lymphocyte counts were actually going down. So by the time they had completed the 6-month fast, their numbers were lower than they were at baseline. From a nutrition perspective, or from nutrition studies, this is essentially unheard of. All we asked them to change was just the timing of their eating. We did not ask them to change the types of foods that they're eating, and they were not on any anti-cancer treatments at this time. The next group of patients, we had 4 participants here whose lymphocyte growth rate plateaued through intermittent fasting. So it didn't go down, but it stopped going up. It just leveled off. And then we had another 5 participants whose lymphocyte growth, it was continuing to go up, but it was going up much slower than it was compared to their historical rate of growth. And then we had 3 participants at the very top here who we saw very little change from. The other interesting point I find from this graph is if we're looking at these dotted green lines, you notice that there seems to be a bit of a lingering effect for about 1 month for those who do return to their normal way of eating. And then for those who we followed for a bit longer, once they did return to a normal pattern of eating, their lymphocyte growth rate ended up matching the growth rate that they had before starting the intervention. So the take home from this is not that we should all go home and start intermittent fasting, but it is something intriguing that, in my opinion, warrants a bit more investigation. Lastly, quality of life, of course, matters as well. So we used a validated 30 questionnaire or a validated questionnaire in people with cancer. We gave it to them before they started the fast, after they started the fast. And this was asking questions around their sleep, their mental health, their physical activity, as well as other symptoms and side effects like pain. And it concluded with these 2 questions here. And what we found was there was a clinically as well as a statistically significant improvement in patients' quality of life from before they started the fast to after they started the fast. For those who also completed the same questionnaire after they returned to their normal diet, their quality of life, I don't have it shown on the slide here, but their quality of life actually went down lower than their baseline level. So this really goes to show how much better our patients were feeling when they were following this diet pattern. Being a dietitian, it makes me think, how does one type of intermittent fasting regimen compare to others? Because there's so many different varieties. We were really fortunate to receive some funding to be able to go back to that same participant pool, put them through the same protocol, but with a different type of intermittent fasting. That will allow us to compare the results head to head to see if one is better than the other or more tolerated by patients than the other. We don't have the results back from the lab on this one yet, so hopefully if I'm back at this conference next year, I can share some of those findings, but it will be very interesting to see those side by side. Lastly, I then conducted semi-structured interviews with these patients as well. So Dr. Scott talked about the importance of qualitative data. So these were just a few of the quotes from the patients that participated, and I'll perhaps just highlight those in the bold words right now. One of our patients said, being part of the study, it put me in touch with good information on diet and CLL. Like, that's kind of the single most important thing to me. Down at the bottom, you'll see a quote, I had a sense that psychologically, I felt like I'm doing something to help every single day. And to me, this really speaks to the fact that food is more than just nutrients. It is culture, it is connection, and for people with CLL, it's also a sense of empowerment. So with that, there were some questions from Dr. Scott's presentation about how you can get involved in research. I actually just opened recruitment for a similar type of intermittent fasting study last week. So if you have an indolent wait and watch type CLL, you may be eligible to participate. So we would put you on a intermittent fasting regimen. You'd work very closely with myself and some others on my team. Be monitored very closely for your safety as well. We've also added a small group of control participants, so people who do not have cancer. So if you have any friends, family, coworkers who might be interested in doing this along with you, that could be an option as well. So my contact information is up there. Please feel free to reach out with questions anytime. And thank you for hanging around. I realize this was the very last session of today, so I'm happy to see so many faces in the audience.
Well, time is running back quickly, but why don't we just take a little bit of time for questions before our closing remarks? Whoop, whoop.
Thank you. I'll be quick. That was great. Thank you both. Question on the intermittent fasting. I have two short questions. Was there a change in the number of calories pre-fasting to post-intermittent fasting? Was that calculated? That would be question one. And my second question is, just so I don't have to talk again, have you done much or read much research on sugars? So I've read a lot of paperwork that said that sugar is kind of the gasoline for some types of cancers, but I've read very little literature on whether it's good or bad or indifferent for CLL. So your opinion on that, please. Thank you.
Yeah, thank you. Really great question. So to answer your first question, we didn't track their calories or exactly what they were eating through their intermittent fast, so I can't make a comment on whether there was changes in the total calories. But what we did do was we monitored changes in weight on a weekly basis, and I didn't share those results here, but changes in weight ended up reflecting individuals' personal health goals. So we had a few people who were intentionally wanting to lose weight, and they did so. We had some who wanted to hold their weight, and they did so. And we had a few who wanted to gain weight, and they were able to do that as well. So I think just the changes that we saw in weight demonstrates that within time-restricted eating, we can still include sufficient calories if needed. And that was something that I was checking in with participants. So if they were unintentionally, so accidentally losing weight with this, then we did intervene to make sure that their nutrition status wasn't being compromised when they were adhering to this 8-hour window. So that was the first one. Second one, sugar and cancer. This is such a loaded question, and I feel like it could be a whole session in and of itself. What I tend to say is that we have seen, or I have seen many patients who have removed all forms of sugar from their diet. So when I'm talking sugar, I'm not just talking things like candies and white table sugar, I'm thinking things like carbohydrates and fruit that also break down into sugars in the body. And they don't tend to do as well as those who do continue to include some sugar in a healthy form in their diet. And part of the reason is some treatments, obviously it depends on what type of treatment you're on, very much targets your cancer cells, but some things like a chemotherapy will hit a lot of your healthy cells as well. So those healthy cells are working double time to repair themselves and stay strong, and they need nutrition as well. So they also will use carbohydrates or sugar as their source of fuel. So that's part one. The second part to that is I do think there's a lot of opportunities to continue to explore this area more from a research perspective. While I think we have a good understanding of the changes in metabolism in cancer, there's still a lot that we haven't totally nailed down. So there's a few different grant applications that I'm part of with some other researchers at BC Cancer that are looking at modifying carbohydrate intake levels to see if that changes clinical outcomes at all. Yeah. Oh, is that okay? Okay. Yes.
Any comments on the aging digestive system and its effectiveness or efficiency in actually absorbing nutrients? I attended a webinar from University of Guelph earlier this spring, which is talking about people 65 and older should be eating more protein than what you had identified there because their system is less able to actually absorb it and process it.
Yeah, that's a great question as well. So we do know that the digestion and absorption process does change as we age. So for example, I had vitamin B12 up there. That is one where many people as we are aging will actually need a supplement because our body struggles to actually break that vitamin B12 apart from the protein. And then as we have less intrinsic factor, which is needed to absorb it, yada, 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 it gets harder. So some things, yes, we do need to modify as we age. That's where I think, again, working with a dietitian one-on-one can be really helpful because it's hard to provide blanket suggestions because there is so many individualized factors, especially when we're dealing with symptoms and side effects. So if you're experiencing nausea, vomiting, diarrhea, that is going to influence your nutrition needs. You will need more protein. You will need more fluids to make up for the losses. So things definitely do shift as we get older. And in terms of the protein comment in particular, this is a highly debated topic in the field of nutrition, is exactly how many grams of protein per kilo of body weight we should be having. The national recommended dietary intake recommendation is set at 0.8 grams per kilo, which is even lower than what I had on my slide. All current research is showing that's not enough. So I strongly suspect we're going to see that increase to 1.0 in the next 5 years or so. But you're right, there's definitely pockets and individualized factors and situations where one may need up to 1.5 grams per kilo, occasionally 2.0, but that's usually overdoing it. Usually 1.5 is kind of the upper end. Yeah, thanks for the question.